Today we are going to learn about history taking and general examination. History taking is the first approach we are going to take when a patient comes to us. Then we will see the patient, and firstly we will start history taking. Now what is history? History means everything the patient has undergone till now. Any diseases, any family conditions, any other conditions of the patient which the patient has suffered from. Any other condition which the patient has suffered from, his family background or his socio-economic conditions, everything which had occurred with the patient till now, which the patient knows about himself, till the moment he came to me, all previous things which the patient knows, we will learn this from the patient. So this is known as history, as we are going to learn the past things about the patient. And why the history taking is important. Suppose a patient is coming to you, and we cannot start writing investigations after seeing the patient without clinically assessing the patient. Sometimes the patient might have a simple thing for which we might start writing very costly investigations or something else. Then that will be a very big burden for the patient. By taking proper history of the patient, we can reduce that burden and we can diagnose clinically what the patient is going through. So this is the importance of the history taking. So firstly, what are the things we have to observe when we are taking the history of a patient? Firstly, we have to look confident before the patient. Only then the patient will give you proper history. If the patient sees that you are not confident enough and you are not that person whom the patient can tell his symptoms, then obviously the patient will hide things from you. He will not freely talk to you. You should allow the patient to talk to you freely so that he can share each of his problems to you, so that you can come to a conclusion that what the patient is suffering from. And we should welcome the patient saying hello. Okay, you will ask his name, then you will shake the hand of the patient. Then we will introduce ourselves to the patient, that I am Dr. this, or I am this medical student, my name is this. Then what is your name? I am working here. And then we will also explain that what we are expecting from the patient, what procedure we are going to do, what tests we are going to do, what we are going to ask about the patient, what we are going to learn about the patient. These things we have to clarify before the patient, so that the patient doesn't feel nervous. If the patient knows everything beforehand, that what he has to tell us, what we are expecting from him, then the patient will not feel nervous and he will be free to tell us everything about himself. So as I've already told you that you should tell beforehand to the patient that we are examining you. I am going to ask you some questions about yourself, so that I can come to I can properly diagnose your problem. What is your current problem? So make sure the patient is comfortable and curtains are in place. In the hospital setting, you can see that there will be many beds. So if there are no curtains, obviously the patient will not be free to talk about himself or show his body parts, if any part is affected or not. So we have to make sure that the proper curtains are in place, so the patient doesn't feel shy before others. So
it is the right of the patient. Confidentiality, we have to maintain the thing confidential. So for this purpose, there should not be any other person there. Okay. Plus, privacy, he or she, suppose this is a female patient, so she will ask for, or she will be expecting that the privacy should be there. So these considerations should be taken.
Another thing is that if sometimes a male doctor is examining a female patient, in rural settings there are not always the female doctors are not available. So a male doctor may also see a female patient. In that case, there should be at least another female staff or another relative of the patient. Any female relative should be present with the female patient. Otherwise, there might be allegations, or the patient may feel uncomfortable.
It may become a legal issue. After, if any confrontation is there, then you will be in trouble.
So, if there is a patient of the opposite gender you are examining, then there should be another attendant or any staff at least, so that the privacy is maintained of the patient. So then we will ask about the particulars of the patient. So obviously we will know someone by the name. So what is the importance of the name? Firstly, we will confirm the patient's name. So if you are calling someone that you come here, then obviously in place of that, if we tell the patient by his name that you come here, then the patient will obviously feel closer to us. He will be able to share more things with the patient. Will know that the doctor knows us by our name, so he must be caring for us. So that is the importance of the knowing the patient's name. Then we will know the patient's age, gender, because there are some diseases which are specific in a group of people, in some age group. So the age will help us to know about the condition. It will help us to clarify that this patient might be having this diagnosis. So the age is important, and the gender, obviously we will see the patient's gender, we will know it. Then the address of the patient is essential, because in some places some diseases may be more prominent. Like in Tripura, in our state, malaria is more common. In other states, the malaria might not be that much common. So we will know the address of the patient, or where he is living currently, or where he is residing, so that we can confirm that what disease he might be having. Then we should also know the occupation of the patient, because in some diseases, in some cases, the disease is related with the occupation of the patient. Like in some coal miners, or in some factory workers, some respiratory diseases might be more, or in some office-related patients, they might be having stress-related disorders, they might be having high stress. So that is also related to the occupation. Then we will know about the marital status of the patient, whether the patient is married or not. So that will also help in confirming some disorders, like some venereal diseases or sexual related diseases, STIs. We can know that by the marital status also. Then we will ask the patient about the principal symptoms. Before that, we will allow the patient to talk freely, so that by himself he can tell everything what the patient is suffering from. We will not ask leading questions at the beforehand. Just starting only, we will not ask the leading questions. We will let the patient tell by himself what problems he is having, and after the patient completes telling that what problem he is having, then only we will start the leading questions. We will keep on asking that what happened next, what happened next. Before that, we will allow the patient to talk freely. Then we will ask the principal symptoms, means the main cause for which the patient has come. Suppose this is season for viral infections, for coughs and allergies. So we will firstly start by what is your condition, like what you are having cough. Then we will ask the duration. Then for how many days you are having cough. Then we will ask the patient to describe. Then whether the cough is secretory, it is purulent, whether the cough is coming out, or it is dry cough, or any other thing is associated with this. If you are having chest pain with this cough, or any other symptoms, we will keep on asking the patient that any other related things, or we will ask the patient to describe his conditions in details. So we will ask the symptoms with duration. Duration means for how much time he is having the problems, and we will ask the patient to describe it. Then we will inquire about the sequence of symptoms and events. That suppose the patient is having cough, he is having fever, he is having diarrhea and all. So we will inquire the sequence of the symptoms. Then first you are having fever, or you are having cough, or you are having diarrhea, or like that. We will tell the patient to tell everything in chronological order, means what has happened first, then next, how the disease progressed, or what the conditions the patient is having one after another. We will inquire about this. Then I already told you that don't ask leading questions in the beginning. In the beginning, we will allow the patient to talk freely, and then only we will keep on asking the subsequent problems about the patient. So again, the chief complaint with duration. Chief complaint is the main complaint for which the patient has come to you. Suppose the patient may be having multiple problems. He may be having pain in his leg, like itching in his fingers. He may be having some vision problem. So everything is not chief complaint. There should be a specific complaint for which the patient is forced to come to the doctor. So he cannot tolerate it more, so he came to the doctor finally. So that may be another thing. He may be having pain abdomen, with pain in the abdomen, or he may be having too much of diarrhea, or he may be having severe fever like this. So everything is not chief complaint. The main complaint for which the patient has come here, that will be the chief complaint. After that, we will ask the remaining complaints about the patient. So we will ask about the history of present illness. As I already told you, that the history of present illness means the chief complaint, he will describe it. Like if he is having fever, then since when he is having fever, what is the duration, then is the fever more during the day or during the night, what is the aggravating or relieving factor. Aggravating factor means if he does something, does the fever increases, or if he takes medicine or does something, does the fever decreases by itself or not. So these are the things we will ask about the present illness. This is known as the history of the present illness, means the chief complaint, he will describe it, he will elaborate it. This is known as the history of present illness. Then we will ask about the past history, like if the patient is having, if the patient is diabetic or hypertensive, or if the patient got admitted with the similar complaints for which he has come to me. If for the similar complaints the patient has been admitted to any previous hospital or not, recently he has gone outside, or he has been admitted to any hospital for these similar complaints. So that will be the past history. So that can give a clue that if the disease is a constant disease, if the patient is having this disease since a long time, or this is a new one, or is this disease related to any condition like diabetes or hypertension. For that condition, this disease is occurring. So by the past history, we will come to know that. Then the family history. We will ask the family history means we will ask how many patients, how many people are there in his family, who are his, how many brothers does he have, how many sisters does he have, do they have the same complaint, like if someone is having TB. So in his home also his father or mother may have TB, or supposing diabetes, or in case of hypertension. Hypertension means BP, if the BP is high patient. In this case, the patient's father or mother may have the same problem. Then we will come to know that this is not the single case. The patient's family is having the same conditions, though. So the patient has come with this disorder. So the family history is very important. Next, we will ask about the personal and the social history. In the personal history and social history, we will ask if the patient is a smoker. So if the patient is a smoker, so obviously he will have more inclination towards the respiratory diseases. He will have more chances of respiratory diseases. So if he is a smoker or not, if he travels a lot, if the patient has recently traveled, then he might have typhoid or traveler's diarrhea. And there are many diseases like that. So we can correlate with that after traveling he has come here and then he is facing these conditions. So obviously due to travel only, due to some food intake outside, he may be having these problems. Then pet animal contact. Then some people may come with allergies, or suppose with rabies. So we can know that the patient has any animal contact or not. If the patient is having allergy to pets like cats or dogs, some people are having allergies to cats or dogs. So we can know if the cough or the allergy is being caused by due to the pet handling or not. We can correlate with that. Then drug history, including allergies. Drug history means some people may take some drugs which they will not tell us. So we have to keep on asking that if you are taking any drugs or not. Drug means medicines. If some medicines may cause allergies in people. So anyone may be allergic to any medicine. Some medicines are more allergic, some are less. So we will keep on asking that recent antibiotic he has taken or not. So that may cause that allergy. If that medicine is causing that allergy and we are giving additional medicines, that will not work if we don't remove the initial cause, the main cause. Okay. Now there is a complaint. Suppose patient comes with chest pain since 2 months. Now in the present illness, what we will ask? We will ask when the patient was completely well. Like before 2 months, were you completely fine, or even before 2 months also you are having this problem? We will ask this to determine from when the problem has exactly started. Then what I have already told you that then what happened, and then describe symptoms in chronological order of onset. Means in chronological order means what happened first. Means sometimes the chest pain may be due to any blow, heavy blow. He may fall down. So he may tell that before 2 months I fell down suddenly. and then I have started having chest pain, and then this, then that, then I started having breathing difficulty, and so on. So we will correlate with that. First, due to his falling, he got chest pain. After that, he is having breathing difficulty, and so on. So we will ask like this in a pattern, which is called chronological order. You can write this also. You just know now. You just understand now. Then we will ask for site of pain. Like the chest has two sides. We will ask for if the pain is in the middle of the chest, if it is in the left side, if it is in the right side. In the right side, it may be mostly due to muscular pain. In the left side, it may be due to any cardiac cause. The patient may have cardiac disease because the chest is in the heart is the left side. So in case of any left-sided chest pain, we can think of any cardiac disease. We can keep on asking in that pattern, that if the patient is having any breathing difficulty or so on. So we can think in that pattern that the patient might have any cardiac problem or something like that. We will ask the character of the pain, like feeling pressure, if he is feeling any pressure inside his chest, if it is dull, if it is stabbing like someone is stabbing you, that is stabbing pain. If it is shooting, if it is too severe pain, we will ask this. If there is radiation, anyone knows what is radiation? Okay, radiation means if the pain or the condition is spreading somewhere else. So like some patient may be having chest pain here, and then they might have abdominal pain or back pain also. So that pain is radiating to that side. So that is the radiation. We will ask about the radiation, if the pain is stagnant there or if it is radiating to any other side. Like the patient may first start having this chest pain, then it may radiate to abdominal pain or something else. So that is the radiation. Then we will ask about the severity. If the pain is very of very low intensity, that if he thinks about the pain only, then only the pain occurs, or if it interferes with his work or his sleep, like the patient is unable to work due to his pain, he is not able to sleep due to his pain, the pain is so severe. So we will ask about the severity.
So sir has already told you regarding the initial of introduction, the particulars of the patient, then history of present illness, right? So in the history of present illness, so for example, one slide has been shown to you about chest pain. If a patient comes with chest pain, how he is going to present to you, how are you going to ask leading questions to him? Okay, so basically
Not only chest pain, any other form.
in any other cases also, you are definitely the patient first. That patient, he or she will come and tell you the initial chief complaints. Okay, then there is going to be history of present illness. In the history of present illness, basically the patient is going to elaborate and be very descriptive about what he is feeling for those few days of what he has already complained, right? Now, for example, a patient has come with chest pain for 2 months. So chest pain, then you will ask him like what is the site of the pain. Now, for example, if she is a patient, she may come and she may tell me, ki, sir, I am having pain in my right side of the chest, right? So when it comes to the right side of the chest, then only we can, when you will be like in third year or final year, you can correlate ki right side of the, whenever there is right side of the pain, we generally tend to give the cause to any cause of a liver or gallbladder, since they are situated in right side of the abdomen, basically right upper lobe of the right upper quadrant of the abdomen, right? You know, right, abdomen is divided into 4 quadrants: right upper, left upper, right lower, left lower. Okay, then there are again 9 regions of the abdomen. We will be discussing you regarding those regions and in subsequent classes, right? So whenever a patient comes with a pain in the chest pain, like the patient comes and asks and tells us, "Kid sir, there is some pain. There is some pain, maybe in the right side of the chest, maybe in the left side of the chest." Then in basis of that, we will be asking what is the type of the pain. Okay. Then there are different types of pain. So the patient might not understood if we ask what is the type of pain, right? So we will be giving that patient some understanding what is the type of the pain that he or she is feeling, right? Then there are different types of pain like stabbing type of pain. What do you mean by stabbing pain? Like, if I take a sharp instrument, right, sharp instrument, and I just press it on my skin, it will feel like a stabbing. A sharp pointy object, just forcing it in my skin, it will feel like stabbing, right? This is called stabbing, right? Movie में आप लोग देखे होंगे, right? This is called stabbing. So this is called stabbing type of pain. Then there is also dull pain. Dull pain is like whenever like we are pressing against a wall. My shoulder is pressing against a wall when I am standing. So after some time I will feel some pain, right? This is called dull type of pain. You can't determine what is the point of pain.
Localize
You
the
can't
origin.
localize the origin, but there will be pain in a broader area, right? So this is called dull type of pain. So first it was stabbing pain, then there is dull pain, then there is feeling pressure. Feeling pressure basically comes with the diagnosis of myocardial infarction, basically. So it's basically whenever a patient, layman term, it's called heart attack, right? Whenever there is heart attack or myocardial infarction in our medical terms, basically what happens, the patient feels like a pressure. There is some pressure, like what we ask the patient if you can feel any pressure. For example, the patient is laying down and we will ask him if we put 2 or 3 or 4 bricks above your chest, heaviness
Feeling.
that's the feeling of pain in case of myocardial infarction, right? Okay, so that's called feeling pressure. Else the patient is not going to understand, right? We have to describe him what can be the pain when we put 2 or 3 bricks above your chest. This is called feeling pressure, right? Then there is again shooting pain. Okay, these are seen in the other different conditions. We'll later tell you in different cases when you get to know, right? Since it's very initial part of thing, so you will not understand about it. Then there is pricking sort of pain also. There are alcoholics tend to get pancreatitis, right? The pancreas, that's an organ named pancreas, it gets inflamed. The pancreatic juice that doesn't get drained, for which there is inflammation, there is swelling, and it causes pain, right? This pain basically the patient feels in the left upper quadrant. With time, what happens? The patient can feel the pain in the back of his
Going to
the back. Initially the patient was feeling pain in the left upper quadrant. Then with some time, the patient is feeling pain exactly at the opposite in the back, right? This is called radiation of the pain. The patient was feeling pain in some region, then the pain got shifted to another region, right? This is called radiation of the pain. The same happens in case of appendicitis also. Okay, the pain initially starts near your umbilicus. Okay, then it keeps on shifting to the right side, right lower quadrant, basically right iliac fossa. Okay, you will understand once we describe you the 9 regions of abdomen in your next practical class. Okay, so this is called
radiating pain for ischemic heart disease.
Ischemic heart disease. In case of myocardial infarction also there is radiation of the pain. In many movies also you have seen the patient starts feeling pain. Patient goes to the doctor, till then the pain is in the left hand, he can't even raise his hand. That's the pain, because this pain got shifted to the left arm, basically the inner portion of the left arm, and also to the left cheeks and to the jaw, right? This is typical of myocardial infarction, or in layman it's called heart attack, right? So these are the types of different radiations and the characters of the pain. In another case, there is also radiation of the pain in gallbladder stone, right? The patient feels pain in the right upper quadrant, basically the right hypochondrium. This pain gets radiated to the right shoulder, not even in the right arm, but the right shoulder. Okay, so basically, why this character and radiation is important to us? Whenever patient comes with
It will cervical spondylosis, lumbar
Lumbar yes. Another thing is yes, sir was telling ki whenever there is cervical lordosis, basically, you know our spine is having some lordosis, and lordosis are there in the spine in two regions, right? These are anatomical only. Okay, whenever there is loss of lordosis, there can be pain. This pain basically shift to the shoulders, both of the shoulders, then into the arms. You will see your parents or your grandparents, sometimes they will be complaining कि अरे मेरे तो इधर उधर दर्द हो रहा है for a long time, right? Basically this indicates कि they might have some issues with the cervical lordosis, or there can be things like cervical lordosis relating to pressure in the nerves that are being spread from the cervical region. So there is pain, there is numbness, okay, there is loss of sensation whenever nerves are pressed, okay. This is now come to why character in radiation is important. Patient may come, patient may tell कि sir, I am feeling pain in my lower part of the thorax, left lower part of the thorax, and also in the left upper quadrant of the abdomen. Pain may be vague, right? It can't be a point. It can be a vague pain in this region. So the character and radiation of the pain will help you determine what can be the cause of the pain.
So this is important. So we have to find out the nature of the pain.
If the patient tells you, sir, my pain doesn't radiate to my left arm, or the pain doesn't radiate to my left jaw, or I don't feel any pressure or like few bricks have been heaviness in my chest, then you can rule out that there is less chances of patient having myocardial infarction, right? The patient may tell you, sir, I am having pain at this very region, but at night it increases. When I wake up from in the morning, I feel like there is irritation in my throat. Okay, and with food, this pain either increases or decreases with food or with water or with liquid substance. Basically, this points you to any cause of stomach or upper part of the duodenum. Right? There can be ulcer, there can be gastritis, there can be any other thing. Okay, so basically, this is the importance of character of the pain, radiation of the pain, and definitely the site of pain, as it has been told to you. Site of pain is very different. Once we know what is the site of pain, we can exactly tell what are the organs that are basically included. Okay, what are the organs that are basically included? Now, if a patient tells, sir, there is pain in my, these are called flanks. You know, I guess from anatomy, these are called flanks. Okay, the lateral part of our abdomen are called flanks basically. So if a patient tells me, sir, there is pain in my right flank, this is the right side, this is the right flank. So if a patient tells me, sir, there is pain in my right flank, you can definitely rule out that there can't be any cause of cardiovascular region. Patient is having pain in the right flank, there can't be any cause relating to cardiovascular. It can be kidney problem, it can be other organs in the abdomen, but no organ in the thorax, right? So that's the importance of knowing what is the site of the pain. Okay. So the site of the pain, then character, then radiation. Then I think sir will continue with the rest of the.
So the severity I have already told you. If it interferes with the work or the sleep pattern of the patient, then there are precipitating and relieving factors. Like precipitating means the things which will increase the pain or increase the condition, increase the intensity of the condition of the patient. And relieving factors are which will reduce the pain or the symptoms of the patient. Like someone is having a heart.
Any one of you are suffering from migraine? Fever. So, can you tell us what are the precipitating factors? What initiates your migraine? Are there any?
Sun rays.
Sunlight. This he said, when I travel through or work in sunlight, so then only it starts, migraine pain starts. So it is the precipitating one of them. Somebody will tell the humidity.
In that case, it's sun.
Or somebody may say coffee, chocolate. Whenever I take chocolate, it may initiate. So these are the precipitating factors. What causes, initiates the pain? And when, how you get relief? When there is a pain, migraine pain, what you do?
So it usually goes away.
And for me, I also suffered migraine. So what I do immediately, if I admit at home, I immediately close the door, close the magnet, done, cool lights off, and request others not to make any noise. Okay, so this will give me some relief. Or it will be relieving for me. Okay, so these are the points you have to ask. How it is initiated, how you get relief from this. So these are the points actually you wanted to explain.
Then another example in this case, in this chest pain, like some people may have angina, which is called chest pain. When the angina means when there is the person is working or the heart is working. In that case, the angina will increase. Angina means the pain of the chest, the cardiac pain. So the pain will increase if the patient is doing any hard work, or if the patient is walking upstairs or doing anything like that. And you might see that those patients may...
This angina pain, actually it is created in the heart. Why it is created? When there will be lack of or low supply of oxygen to the cardiac muscle. Okay, this is called ischemia. Inadequate supply of the working cardiac muscle. The cause may be different. Because maybe a problem with the coronary circulation, coronary arteries. There it may be it has become narrowed. So when it is needed, more oxygen is needed, but it is unable to supply. In that case, there will be angina pain. This is having radiating character. It may radiate to your limb also, to the neck, to the limbs, particularly to the left side.
So the relieving factor for this pain would be rest. Suppose the patient is resting. In that condition, if you ask the patient...
The angina patient will there. When I take rest, it goes. Means then my heart has to work less. So then at that time, the patient may get sufficient oxygen. So there will not be it will go away. He or she cannot keep pace when they will be working with someone else, but they are running normally. But the patient, he will not be able to keep pace with them. He will or she will be always behind. So this way, they can tell, or you can ask whether it happens for you on exertion, because on exertion it may develop, or climbing stairs.
So after precipitating and relieving factors, we will ask whether the patient had this condition before or not, whether this is developing newly, this is the first time, or the patient had similar episodes of this condition. Like if the patient tells in this condition of angina that the patient was already having these symptoms, like if he is working hard or moving around, then he is developing breathing difficulty. If the patient told that since 5-6 months I am having this problem, then we will know that this condition the patient has already faced before. This is a chronic condition. It is not new. So we will ask whether the condition is new or not. Then the pain will be associated with nausea and sweating. Again, in angina, the pain will be associated with nausea. So like if the patient is having nauseating. Nausea means if the patient is having tendency of vomiting. Vomiting is, you know, that we are throwing out. It is called vomiting. And we are not vomiting. We are likely to vomit. That is we are having the urge to vomit. This is not nausea. So in case of nausea, or if we are sweating too much, in that case also, in severe angina patients, the patient will have these symptoms like nausea and sweating. So there is a note that when the patient is unable to give history, so sometimes we may receive some patients in ICU or in emergency who are in such critical condition that the patient is not able to speak to you. the patient is nearly unconscious or even unconscious. So in that case, in an unconscious patient, obviously we cannot ask the patient that what are your conditions. We will not wait for the patient to tell. Then we will ask his relatives or friends or whoever has brought him. The person should be reliable, not that someone from the road has picked him up. We will ask him that what was his condition. Obviously he will not know anything. So we will ask his, like if it is a baby or if it is a small child, we will ask his mother. His mother will know best what has happened to the child. Or mainly we will ask someone who is reliable, who is more close to the patient than others. We will ask that person that what problems the patient was having earlier or what problem he is having now. So this is how we will take the history from any relative. So again, we will ask for previous illness and hospital admission. I have already told you that if the patient has been admitted with any condition previously in any hospital, or the patient is having this particular illness since some time now, so we will ask about the previous illness, or any other illness which might lead to this current condition, we will ask about that. So we will also ask if any operations has occurred, like some patient might be having pain in the abdomen. So we will ask if he had any previous operations, like suppose he had any operations 2 months ago in the same region. So there might be any infection in that place. So we can find out by that, by asking that if the person has undergone any operation. Like if the person has got his gallbladder removed, so obviously he will not have any gallbladder pain. So we will rule out by asking these questions. Then medicines, we will ask what medicines the patient is taking. So suppose the patient has come with fever and he is taking antibiotics or something. So we will ask the medicines, about the medicines, so that we do not prescribe the medicines again, that we are giving the same medicines again and again. So we will ask about the medicine, already the patient has received treatment or not, and then we will go further. We will change the pattern of the treatment. Then we will ask about the family history. I have already told you that in case of hypertension or diabetes, we will ask the patient if his mother, his father, his brother, any family, any relatives, they are having the same condition. Then we can diagnose that the patient is having familial hypertension or familial diabetes, like that. Then history of death, like someone's father has died due to cardiac arrest, or due to heart disease, or his uncle or his mother has died due to cardiac arrest. So if the patient has come with chest pain or like something like that, then we can think in our mind that okay, that this patient might also be having this condition, that there may be a family condition of this heart disease. So the patient's mother has died or the father has died or anyone near person has died. So again we will be asking how many brothers and sisters do you have, if they are all right or not. Then we have already discussed, we will ask about their job, if some diseases are caused by stress in some high profile jobs, or there may be diseases due to overwork, or in some factories there may be diseases. So we will ask the patient, are you married, or how many children are you having, their age, if they are well, if there is any genetic disease, we can find out that if the person's children is also having this disease or not. So again we will, the same points are there, smoker or non-smoker, any male or any medicines. If the patient is old, we should ask whether the patient is living ground floor or upstairs. If the person is having difficulty of breathing, or if he is having general weakness, we will ask the patient whether he is having his home in the ground floor or in the upstairs, so that we can diagnose that it is being caused due to his regularly going upstairs or not. So we will ask if he is having difficulties regarding toilet, cooking, shopping. Like if the patient is having difficulties in doing these simple tasks like cooking and going to toilet, then we can judge if there is a severe heart disease or not. The patient is unable to go to the toilet properly, so we can judge that if the condition is severe or the disease is.
A lot of things have to be asked. No? So at the same time, you think one thing: why I should ask this question? How it is going to be related? So you have to find out this. I have to take, it has got, though it will be appear to you, it has got no relation with any disease. So this sort of question you should ask yourself. Why should I ask this question? Is it relevant? Is it relevant? Definitely it has got relevance, but how? You have to know that. While history study, it should be related. It should have relevance.
We will not ask any question to any patient. Suppose a patient with heart disease, already known heart disease has come with chest pain. We will not ask him whether you are having pets, you are having pet allergy or not. So we will ask what is relevant to the patient, like what we can relate with the condition, with the disease. Only those questions we will ask. We will not ask everything to everyone. Then
Now I wanted to tell you only this thing. The relevant questions. Unrelevant will be knowing. These are the unrelevant. It is not at all related to any disease process. So ask the relevant questions. These questions may not be exhaustive. I will not ask anything beyond that. So if you think necessary, if you link those questions to you are able to think those questions to the disease process, then you ask. Only thing, it should be relevant.
Then after taking proper history of the patient, we will come to the examination. So after taking history only, we will know that where the patient is having the problem. If he is having problem in the abdomen or in the chest or in a particular system, he is having difficulty in the respiratory system or in the abdomen, in the urinary system. And then after knowing only, we will proceed in such a way that we can find out the cause. Proper history only, we can know that which system we have to examine. If suppose you are not having a single patient in your OPD, there might be 10 patients, 15 patients. So you will not go on examining every single system of every patient. Then you will not be able to complete the procedure, your OPD. Then we will go by systems. Firstly, we will go for general examination. We will go for general examination in details. And then we will go for systemic examination of a particular system.
So, as Sir has already told, there are some important points we have to all know before taking a history and why we are taking history. So, these are some important points as Sir has already told. We have to look confident, then we have to welcome the patient by saying hello, we have to shake our hands, and then introduce ourselves, why we are taking the history and why we are taking. So, this, and after that make sure the patient is comfortable and he is under the curtain and in a privately, so make this thing, and after that confirm the name, age, gender, address, occupation, these things, and whether the patient is married or not, and the reasons why we are asking, as Sir has already said, so I'm not going into that. So after that, the principal symptoms, the durations, tell the patient to describe by himself. If he is free, then he will automatically say it within his own words. So inquire about the sequence of the symptoms and the events. So what is the sequence of the event? So if the patient comes with having chest pain, shortness, fever, so we have to go with the chronologically. So if the patient is having fever, say for 10 days, so we have to write fever for 10 days in the first. So after that, we have to go for if the patient is having shortness of breath, after that, so it will come next. So say the patient is having shortness of breath for 5 days, so it will come next. So chronologically, we have to write this. So after that, chief complaints, duration, then a history of the present illness. So since when it started, say the chest pain when it started, say the shortness of breath when it started, we have to ask the date for how long it has been started. So we have to describe that. So in past history, we have to ask the patient whether he had any other illness from previously, whether he is having hypertension or not, whether he is a diabetic or not, whether from previously he is any lung disease are there or not. So we have to ask this. Okay. So any surgical history. And familial history is also very important. So in families, there is some genetic disorders which passes from to the offsprings. So after that, they get it. So that is also important. Personal history, whether the patient is a smoker, whether he is alcoholic or not, whether he is addicted to some drugs or not, whether he is taking any IV drugs or not. There are many disorders like that. So then travel history, then whether he has having any pet or not. So in there are many conditions we get infections from pets. So zoonotic diseases, we know it. So that is also important. Any drug history, whether he is allergic to any drug or not. So as I said, we have to describe the chief complaint. So if he is having chest pain for 2 months, say, so then chronologically, as I said, so the same thing. The site of pain, from when it generated, from which part of the say from the chest the pain generated, from which part of the chest, whether it was gradually started or it was acute, the character of the pain, whether it's dull, stabbing, shooting, or heaviness, and whether it's radiating or not to any side of the body part. So the severity, whether it interferes with his work or sleep, whether it aggravates or whether it relieves. In chest pain, some patient might say that when I work or when I jog or when I cycle, that time it increases. Sometimes it relieves during sleep. So we have to write that. So whether he had the similar history from before, whether he had or not. So we have to ask that also. So any other associated symptoms, like if the patient is having shortness of breath or chest pain, whether he is sweating or he is having nausea or he is vomiting or not, that also have to ask. And in some patients, if he can't give the history properly, we will get some patients like that also. So that time we have to ask his family members, his close ones. The previous illness, hospital admission, that I said, any operation history, any medications, whether he is taking or not. We have to ask the medicinal history also, whether he is under any medication or some. In some medicines, we get some adverse reaction, adverse effects, side effects. That also we have to rule out from any medication, whether his present illness is going on or not. So father and mother, familial history, whether they having or not, hypertensive, any diabetic, any history of death, cause of death. This is. And about the job, whether the patient is married or not. In some sexual diseases also we get some diseases, so that is also important to ask. Children's, how the smoker travel, that I already said. A patient has ground floor. See, in some COPD patients, in chronic obstructive pulmonary disease patient, if the patient is old, naturally this happens in smokers. So if they walk fast or if they climb upstairs, so they will have difficulty in breathing. So that also we have to see. So this might be an aggravating factor for these patients. So any difficulties regarding toilet or cooking or shopping, like in some patients they can defecate properly, or they are having after taking food they feel going to toilet. So some diseases are like that also. So whether he can cook properly or not. So in some higher functions, in cerebral, some functions there, the patient cannot cook properly. You will find problem in gaits. His hands, he cannot cooperate with his orders. So there are some diseases like that also. In shoppings, and this. That's all.
Chronological order. Then comes the history of present illness, that is description of the chief complaints. Then comes the history of past illness. Then comes the family history, social history, educational history, and then personal history also, right? After history taking is over, we start with basically examination of the patient.
Important one.
So once patient comes and gives you a relevant history, for example, a patient came with chest pain. Patient have come and has told you, "Ki, sir, I am having chest pain for this and this time," and he has described it as per the history of present illness. Now, you can say, "Ki, sir, I can diagnose ki the patient is having issue with the cardiovascular system," right? But general physical examination is very important, since the thorax also involves the lungs, that is the respiratory system. So both the systems are there in the same region, right? Now to understand which system is basically involved, we have to go through the general physical examination. Okay. Now these are the usual sequence of events that in patient care, right? From history, examination, problem list, differential, diagnosis, investigation, diagnosis confirmed. One thing you can see here, there is differential diagnosis, there is diagnosis confirmed. In two places we have written diagnosis, right? Basically, differential diagnosis means, for example, the patient has come with a chest pain. We can come to a conclusion after the history taking or after the general physical examination is over, the patient is having problem regarding like myocardial infarction. Sir also mentioned that there is angina. One word has been mentioned by the sir, that there is angina. Angina is different, myocardial infarction is different, right? There are two different pathogenesis to both of them. So, as after the general physical examination is complete, okay, after every examination is complete, we come to a conclusion with few diagnoses, right? Basically, before completing the systemic examination, we come to different diagnoses with ourselves. There can be a patient, this patient can have angina, this patient can have myocardial infarction. There are many other causes of chest pain related to cardiovascular system. For example, there can be a case of a patient can have pancreatitis. I have told you the patient can come with pancreatitis with this pain in the epigastric region. Since this is a very vague area, you can't point at this very thing ki this is related to cardiovascular and this is related to gastric. Okay, so these are differential diagnoses, like one thing representing many illnesses. Then comes, after our general and systemic examination is complete, we come to provisional diagnosis. Provisional diagnosis is a typical one diagnosis which we conclude after our all examinations are over. Okay. Then after investigations, we come to the final diagnosis. Okay. This final diagnosis is the diagnosis based on which we will be treating the patient, not depending on the provisional diagnosis, right? The patient may come with pain. So once a patient comes with pain, and after we have our provisional diagnosis, and before the reports of the investigation comes, we basically give some pain relieving medications so that the symptoms of the patient can be healed till the report of the investigations come. Okay, so based on provisional diagnosis, you can just give some symptomatic relief to the patient until the diagnosis is confirmed and you reach to the conclusion that yes, this patient is suffering from myocardial infarction or angina, and then you can start with different medications that are being provided for different diseases, right? Now we will see what are general physical examination of a patient. See, once a patient comes to your clinic, okay, once a patient comes to your clinic, the appearance of the patient is the very first thing you have to observe. The appearance of the patient, right? You can see the patient will look like their posture is a something bit forward, like, okay, their head is a bit tilted forward, their posture. Also, there can be this patient when coming to your clinic is accompanied by a attendant. He can't walk properly, right? Or you can see the patient can't open his eyes properly whenever he is being taken, he is being brought to your chamber or your clinic. Or you can see a case of road traffic accident where the patient is in a stretcher. Okay, so there are different things, different appearances of a patient coming to your clinic. So there comes the general appearance of the patient. How does the patient look? Because once you complete your final year, you will come to know कि appearance of patient gives various type of clues. Yes, this patient has a bit of issue with his cardiovascular system or renal system. Suppose a patient is coming and you can see the patient has a large swollen limb. Both the limbs are swollen. Definitely there is fluid accumulation in the tissues, right? So it can be related to renal system, cardiovascular system, gastrointestinal system. Anyway, it can be related. The appearance of patient is the very first thing you observe when he or she comes to your clinic, right? Then comes the alertness or the general behavior. Basically, in clinical practice, what we say is, if the patient is oriented to time, place and person. First is consciousness, like all of you are conscious unless someone is feeling sleepy, then it can be a bit subconscious, right? But else everyone else here is conscious. So this is conscious. A patient of road traffic accident or a patient has fallen from a very like for 3 or 4 storied building, the patient has fallen. This patient can't be conscious, right? The patient has come totally unconscious. Now from there onward, you will take history from the attendant who has accompanied the patient, right? Then there comes, after consciousness, there comes the orientation. What is orientation? For example, if I ask someone, what is today's date? Tell me, what is today's date? 16. What is this place? This place, the physiology department of Shantiniketan Medical College, right? And who is the person sitting just behind you? Who is the person sitting behind you? She is your batchmate, right? So this is orientation to person, orientation to place and orientation to time, right? So once a patient comes, you see the general appearance, you see if that patient is conscious or not, you see if the patient is oriented to time, place and person. So to see if the patient is oriented to time, place and person, you have to ask the patient, what is the date today? Where are you right now? Or who are the attendants? What is their relation with them? So you will get to understand what is their orientation to time, place and person. Then comes our one more thing is there. Basically, it's not in the slide. You have to see their hands and nails. It comes actually later. There is pallor, right? You have to look for pallor. Pallor is when there is very less. When do you see pallor? What is pallor? Pallor. What is pallor? When do you see pallor?
Yellowish pigmentation.
No, it's not pallor. Anemia. So there is reduced amount of hemoglobin or red blood cells that has caused anemia. In those patients, you will see pallor.
Who said pain?
Huh?
Who said pain from the guy on the
No, not pain. She has told yellowish.
Who? I have to see her face.
She has told yellowish of that's
What is pain?
pain. Someone has told no.
What is pain? No.
No, sir. So pallor, right? What she has told is yellowish. What is it called? Jaundice is the clinical diagnosis. What is it called? Icterus, right? So there is pallor, there is icterus. Then you see there is written hands and nails. What do you see in hands and nails? Okay, color. Color of what? Nails. What do? Okay, one by one. What do you see in nails? Basically, bluish can be seen. Tip of the finger, bluish can be seen. Right? In cases of cyanosis, that's called cyanosis. What is cyanosis? Deoxyhemoglobin more than 5 g/% is called cyanosis. Right? Deoxyhemoglobin means hemoglobin bound with CO2. Deoxyhemoglobin more than 5 g/%, I think. Sir, if I'm correct.
I have to ask one question.
Achha.
By examining the nails, can you identify deficiency disorder of the knee? The knee animal?
Examination of nails.
What? Calcium.
Calcium.
Huh?
Sir, iron
What?
deficiency.
Yes. Lead to what?
Everybody?
What is this called? Basically, what do you see in?
Shape of the nail.
What do you call the change in shape of the nails or the nail bed? What do you call it?
It becomes sometimes it may be flat or it may be
Spoon shaped. What is it called?
what is the condition? What it indicates?
Iron deficiency.
Who said? Good. This indicates that there is iron deficiency.
Yes.
Anywhere the cause is iron deficiency.
What do you see in nail bed basically in general physical examination? Many of you have told ki there is this swelling of the tip of the finger or the nail bed basically. What do you call it? This is called clubbing. You can see if you do like that, everyone can try both the index finger touching each other, right? You can see there will be a quadrangular space in between the nail beds. All of you look, see there will be a quadrangular space, a space like that, kite shaped space. है ना सब में? Everyone has it. So you people don't have clubbing. What is clubbing? Clubbing is swelling of the subcutaneous tissue under the nail bed. Okay, there are many causes of clubbing. So basically when there is swelling of the tissues or the proliferation of the tissues under the nail bed, what will happen is there is an angle. That's why you can see a space, right? If the angle is lost, you can't see a space. Both will be touching completely with each other. Okay, so because of this proliferation of the tissue, there is loss of the angle of the nail bed, that leading to clubbing. Right? So what we see in the hands, in the nails, we have clubbing. Then Saresh told you iron deficiency anemia. Those spoon shaped, right? There are many other conditions that can be diagnosed just by seeing the nails.
White spots.
Yes. What is this called?
This is I think deficiency of a vitamin.
What is this called? What is this called? Tell me what is koilonychia is there, leukotrachea is there. Do you know? Okay, we will be discussing you with. Okay. Then there are hands. For hands, I have told you, right? You can see a cyanosis in there, in the tip of the nail. In many, you also know ki there is something called frostbite. When exposed to so much of cold, there is frostbite. What happens? There is very much spasm in winter. In winter, what happens to our body? There is spasm so that heat can be conserved. So in the tip of the nails, when they are exposed to so much of cold, there is very much spasm, and blood supply of our finger are basically by a single vessel, right? In the digits, I am telling about the digits. Once the blood supply is lost to some extent, there happens is bluish discoloration of the tip of the fingers. These are called cyanosis, right? So there what we have seen till now, first general physical examination starts with what? General appearance, then conscious or not, then orientation to time, place, person, then comes what? Okay. Now, okay, peripheral rhythm is written later. Okay. There is just for some time, don't consider this line, radial pulse and blood pressure. Okay. Once a patient comes, try to diagnose or examine whatever you can without touching the patient. For example, general appearance, consciousness, orientation to time, place and person, their fingernails, nail bed, tip of the fingers, this can be seen by bare eyes, right, without touching the patient. So then next comes lymph node. There are many much number of lymph nodes throughout our body. For example, in our cervical region, there are few hundred group of lymph node. The deep cervical.
Then what is the water lymph node?
Oh, what is a lymph node basically? Has it been told to you or taught to you in your class? What is lymph node? Anyone can say?
Or whatever you know, if it has not been taught. So
Yes, what is your idea regarding lymph node? Anyone?
Lymph nodes are the sites where the beta cells,
Beta na B
B lymphocytes get
transformed to?
They get exposed to that.
So basically maturation.
Yeah.
Maturation happens in the lymph nodes.
Lymphocytes.
Lymph node. There are many number of lymph nodes, right? So you can say ki sir, lymph node can we see in bare eyes? Yes, you can see. Sometimes you can't see, sometimes you can see. In many cases you will see small children having large swollen area there. Many of the clinical images you will see. We actually come to many advertisements also during whenever we are seeing television, these things comes, right? So basically lymph node is somewhere there is maturation of lymphocytes, right? There are many processes, recruitment, maturation, then there are following processes are there. So let's not go into deep into this. So there is lymph node, there are axillary lymph node, cervical lymph node, and there are many more lymph nodes throughout your body, right? What does basically lymphatics does? There are also called lymphatics. They are same like arteries and veins that drains from one lymph node to other to finally get drained into a organ called thoracic duct. So there are groups of lymph nodes. There are then lymphatic channels. They drain to thoracic duct. Some lymphatics also drain to the inferior vena cava. The final destination is reaching to your blood circulation,
Yes.
to your venous blood, then to your heart, right?
What would be the color of this lymph? White. Why it is white?
So RBC is colorless.
It can be what is transparent, maybe transparent like water.
Yeah.
There will be what? What are you sending to? What it is absorbed? Fatty things, no? These chylomicrons, they will give it a white. These are white, milky.
Okay, right? So there are cyanosis, there is clubbing, there is lymph node swelling, right? Then there is, we also see the face, eyes and tongue.
Very important. What you can identify
With face, eyes and tongue.
These are very important things.
See, in eyes, a patient who has come with severe dehydration, the eyes will be not swollen, sunken. The eyes will be sunken in a patient with a case of dehydration. You see the tongue of a patient, you ask the patient to show the tongue, you will see the tongue surface will be completely dry. You can understand the patient is having dehydration. You can link this dehydration to if the patient comes with a complaint of, sir, I am having diarrhea for like 2 to 3 days. Daily I have to go 10 to 15 times For 2 to 3 days I am having diarrhea. So you can understand by that ki yes, this patient is having severe dehydration, I have to admit this patient, right? There also comes the eyes. As you people have told, we can see icterus, we can also see pallor in the eyes, right? In subsequent slides I will tell you where to look in case of pallor and in case of icterus, where to look, in which part of the eye you have to look. Then there comes peripheral edema. I have told you, right, once a patient comes, you can see there will be swelling of the legs, right?
Can you tell us only one point? What causes, one of the basic point, what causes edema? Plasma? Osmotic pressure. What happens? It reduces or it enhances? Osmotic pressure is reduced or increased? Why it is reduced? What is there? What are the causes of reduction in plasma osmotic pressure?
Basically, what maintains the plasma osmotic pressure? Albumin.
Who
Yes.
prepares?
Who prepares albumin?
Huh? Who prepares this albumin? What is the source? We have
Source
learned. Source of plasma proteins. The liver.
Liver.
So if your liver is not functioning well, will it be possible to generate sufficient amount of plasma proteins, albumin? So if it is not, then there will be reduction in,
Albumin.
then there will be disturbance in fluid exchange. More fluid will be accumulated in the tissue spaces. So this may cause edema. There are other causes. Renal causes may also cause.
Basically, that's how you join the dots. Patient has come with edema. You can see there is edema, right? You can go to the physiology. Ki either the patient has low osmotic pressure or high hydrostatic pressure also, right? This high hydrostatic pressure can be a cause of renal problem. Because the patient can't urinate properly, there may have any anatomical problem with that, or there are stones for which the patient can't urinate properly or micturate properly, right? So there is accumulation of urine, there is back pressure, there is increased hydrostatic pressure within the vessels, right? So there will be accumulation of fluid where? In the tissues. The same way,
Osmotic pressure is 25 millimeter mercury.
it's same, normal.
Usually, if it goes, the hydrostatic pressure tries to send the fluid
Outside
from
the
capillary to the outside in the tissue spaces, whereas osmotic pressure tries to hold it. So now the difference between osmotic pressure and hydrostatic, osmotic pressure is okay, it is normal, but hydrostatic pressure has
ये तो
increased.
hydrostatic,
So
oncotic,
the
osmotic
difference
और
has
oncotic.
increased. As a result, more fluid will come into, will enter into the tissue spaces. Less fluid will be entering into the, from tissue space into the blood vessel, into the capillary. So there will be accumulation, there will be
Edema.
edema.
So you can relate edema to causes in the gastrointestinal system, that is liver. You can also relate it to renal system, kidney. You can also relate it to cardiovascular system also. A case of
Important thing.
yes.
Immediately when you find edema, so you should think about what are this? Disorder in, it indicates there are disorder in liver, kidney or
Hard, right? So these are the points on which you have to examine the patients, the general physical examination of the patients, right? So see, I have already told you general appearance. Does the patient look ill? Once a patient comes to your clinic, you can easily see and tell ki haan, this patient looks ill. The patient's appearance is not of a normal person. The patient also, you can see if the patient has come by herself or himself, the patient is definitely conscious, right? If he is brought by an attendant, definitely the patient can be definitely be conscious, but he either there can be also some causes that would have led to loss of consciousness, right, since he has been brought by some attendant or some other people, right. For example, in case of a road traffic accident, definitely the patient's relative may not be present at the site. He will be brought to the clinic by some bystanders who are there, right. In that case, you can't take history from those people, those bystanders who are accompanying the patient. They may tell you what has happened so that you can write, but when it comes to history of past illness or medical family history, you have to rely on any attendant, right, the patient's relative. So in general appearance, you will see if the patient looks ill or not, if the patient is alert, confused, drowsy. You can also see if the patient is cooperative, happy, sad, because there are psychiatric problems that can lead to mood disorders. The patient may be happy, the patient may be sad, the patient may be having no emotions at all, right? These are basically helpful in case of psychiatric illnesses. Okay. A patient can be obese, muscular, also wasted.
Wasting of muscles. Reduction of muscle mass. This is wasting. Okay. And how can you measure whether somebody is wasted or not? How will you know
BMI.
that, yes, he is wasted?
Some circumference is involved to see if there is.
Bicep?
Bicep not. How come you can measure bicep muscle circumference?
What is it? Huh? What is this? Upper arm or lower arm? Upper. And what is this position? Mid upper. This position is mid upper.
Mid upper arm circumference.
And take the circumference. Mid upper arm circumference. This is very important, particularly important in case of children. Okay, so what is there when you touch or hold the hand, upper arm of a kid or an infant under 5 years or old, and what would be your feeling? Hard, soft, soft. Softness is because of muscle it is heavy, or because of fat? Fat. So the kids, small kids, they cannot hold properly. They are having generate less force. This means their muscles are less. More is fat. Okay. So as the child will be growing, what will happen? He can hold. Now there is, it can more precisely. Okay, it can hold something. So there is muscle is developing. Okay, so the fatness will be reducing and muscle mass will be increasing. Okay, so it is thereafter when the kid become 6 years or above, gradually muscle mass is gradually will be increased. So if there is any reduction in MUA3, mid upper arm circumference, that it will indicate there is wasting of muscle. Wasting of muscle doesn't mean number of muscle fibers has declined. No. Number of muscle fibers remains same. Only diameter. Only number of muscle fibers cannot be increased.
Hypertrophy.
By any means. It can be hypertrophy. Its diameter may be increased. Its content of myelin and myosin can be increased. Within the number of mitochondria can be increased. The size of the mitochondria can be increased. Number of capillaries around the muscle fibers can be increased. These are the. By this only we make hypertrophy of our muscles by doing regular physical exercises. Okay, so wasting means loss of muscle mass. Means that diameter will be gradually Increasing. And BMI, body mass index. Anybody can tell you the formula of BMI?
Weight by
Body mass index.
total weight by height in not in centimeter.
Height in meter.
Height in meter, weight in kgs. Weight by height square. Weight by height square.
So you will get a value.
What is the normal range? Normal reference range?
18.5 to 24.9. Okay, this is the normal range. If your BMI is 25 and it is within 29.9, no,
Not obese.
overweight.
This is called overweight.
When it exceeds 29.9, that is 30 onwards, then obese. Again, there are obesity 1, obesity 2, different grades of obesity. And when the value comes below 18.5, then it will be
Underweight.
Again, if it is below 15, I think
Below 14.5.
it is severely
Severely underweight.
underweight. Usually, these are also wasted. Some boys who suffer, or some children who suffers, long-term malnourishment, undernourishment, long-term undernourishment. So what may happen to him? Number one, his height will be not normal. We call them stunted. When compared to age, then his height should be like this. But it is not like that. Must below this. Then we call the boy or the child is stunted, stunted. And at the same time, he can be wasted. Stunted as well as wasted. Wasting and underweight, these are signs, symptoms. These are actually, it happens because of acute malnourishment. It is developed in last few months. You are not eating properly, you are not getting nutrients, so this will be reflected in your body weight. There will be less body weight, but your height will not be affected. Your height will not be reduced. But if your malnourished since 5 years of age, 4 years of age, and it is continued up to 10 years of age, so what will happen? No, there will be no growth as well as there will be no adequate amount weight. So the kid will be suffering from stunting as well as waste. So now you got the idea of obesity, muscular wasting. So another thing regarding physical we can classify somatotypic. You know? Yes, okay. Somatotypic. Somebody's body structure may be endomorph, some may be mesomorph, some may be ectomorph. The term itself defines endomorph, fatty, mesomorph, muscular, ectomorph, thinning. Means there is only skeleton. Okay, there is another classification of apple shape and pear shape
Body shape, yes.
So by that way, you can predict cardiovascular future. Somebody either is a
Distribution.
relationship with cardiovascular diseases. So there is a chance of developing CVS. The obesity, the consequence of obesity, you know what is the consequence. So they may ultimately, this is type of obesity. So pear-shaped body and another apple-shaped body. Okay, so there,
Can't remember for now.
there's some it's a cliche body. The females whose body shape is like this, abdomen is like this, and the buttock is relatively smaller.
Pear-shaped is also.
What is the shape? What is the
Pear-shaped
shape?
is slow.
Apple shape. They are most likely to develop CVS as well as diabetes. Not only this, another disease that actually the girls they suffer usually this is more prevalent in urban life. This is polycystic ovarian disease. So actually these are common in urban children, urban women, urban adolescents. Because of this physical change. So most of the patients who will be going to doctor because of this problem, their body weight will be high.
So basically, the treatment in polycystic ovarian syndrome is lifestyle modification is the first thing. Then if it doesn't correct, then we have to input medication.
Another condition also develops, that is hypothyroidism. So when there is hypothyroidism, pH is like it for normal or below normal, but pH level is high. So we call it hypothyroidism. So in that case, there is tryptophan production is less. So thyroid hormones are actually catabolic hormones. It produces oxidation of foodstuff. So when the level will be high, so there will be more oxidation, their body temperature will be high, their BMR will be high. So because of this, always it is combustion, there is combustion, oxidation of stored food. So either it will be fat or it will be something other nutrient. So gradually it will be becoming tea. So related physiology. And those who are hypothyroid, their TP-T4 is less, oxidation is less. They are eating, whatever they are eating, mostly they are depositing. Mostly they are depositing. As a result, what happens? They will be gaining weight. And gaining weight will hinder the activity of the reproductive organs. It will hinder the hormonal, it will cause hormonal imbalance. The outcome is one of these polycystic ovarian disease, and this you know, this is one kind of infertility. So ultimately, this sort of person may in future may suffer infertility, isn't it?
Also, one more thing is there. In general appearance, you will see if the patient is in pain or distress. Their outlook will tell you if that patient is in distress. Also you can know whenever you feel pain, your face will reflect that you are feeling pain. One more thing is there. When we do in next class, we will be teaching you about abdomen examination, right? So in abdomen examination, when you palpate, basically pressing over different parts of the abdomen, when you palpate, you never look into the abdomen. You look into the face of the patient while palpating, because the pain or any distress can be reflected in the face of a patient, right? So these are the points under which comes the general appearance, right? The next is the hands and nails. As I have told you, whatever you will see, there are many other factors, right? Raynaud's phenomenon, right? Raynaud's. I have told you the patient coming in exposure of the cold get bluish tip of the fingernails, right? So in same as happens in case of Raynaud's phenomenon also. Then there are things like nicotine staining. In a country like India, the most substance abuse is basically nicotine. Basically in our state also, the most amount of abuse of substance is nicotine. It's not weed, not smoking something else, not even alcohol. Okay, nicotine is the maximum amount of substance that is being abused in our state. So whenever you will be seeing any patients in your UG curriculum only, you must have to look into patients' palms, fingers and palms. Okay, there you can see there will be staining by the nicotine, and it can easily be visible. And whenever you basically match with both the palms, you can easily see which palm is being roughly used for nicotine purpose, right? Then there will be peripheral cyanosis, as I have told you. Then palms for palmar erythema. One more thing is there. Palmar erythema is there. Erythema means what? Erythema, anyone can tell me what is erythema? Huh? Erythema? No, it's not irregular heartbeat. Heartbeat irregular, it all comes into pulse. Erythema is reddishness in the palm. You can see there will be palmar erythema in case of chronic liver disease and pregnancy. In case of pregnancy, you might not see, but in case of chronic liver disease, you will definitely see. What is erythema? There is one more point is there called spider nevi. In case of chronic liver disease, because of increase in amount of estrogen and components of estrogen, you will see spider nevi. During your subsequent classes, we will tell you what is spider nevi, and if we get any patient, we will definitely see you the case. What is a spider nevi, right? Then there comes Dupuytren contracture. You will get to know it later, right? Even if I tell you, you will not understand, because unless you see a patient and see the contracture, see, it is basically thickened palmar skin to the flexor tendon. Oh, you know what is the flexor compartment, the extensor compartment, right? Now the flexor compartment, what happens is there is thickened palmar skin. The skin, that is this one, palmar skin, is basically thickened to a great extent that actually is Dupuytren's contracture. The palmar skin thickening also happens in other clinical issues, medical issues also, right? So once you see a case, you will basically understand these things. There comes the clubbing. What I have told you, there is loss of angle, right? There is, see, the tissues at the base of the nail are thickened, as I have told you, which actually what does, there is loss of angle and there is no quadrangular space when you touch both the nail beds together. Then there comes the causes of the clubbing. Clubbing basically happens because of anoxia in the fingertips. Okay, when there is less amount of oxygen but the tissues need to survive, what happens is there is proliferation of the subungual tissues, the tissues that are present below the nail beds. There is proliferation of that, which actually leads to loss of the angle, which is called clubbing. There are different stages of clubbing, basically 4 or 5 stages of clubbing. We will tell you in subsequent classes, right? So there are many causes. What can be the cause of anoxia, right? Anoxia means lack of oxygen flowing into a tissue. In a case of heart disease, infective endocarditis can lead to this. In a case of lung, see carcinoma bronchus, bronchiectasis, fibrosing alveolitis. Then in case of liver cirrhosis also, and in case of Crohn's disease. Basically, in case of clubbing, there are many theories to it. Some are anoxic and some are other theories to that, which are basically not till being described properly in any of the textbooks or any of the journals. Okay. Then there comes, after clubbing, there are, see, other things are there in the nails also. I have told you what is koilonychia, iron deficiency anemia. What happens is concave. The nail becomes concave. Basically the spoon shaped. Right? This is called koilonychia. There is leukonychia, white nails. Some of you, one of you have told, right? White nails. This white nails is basically koilonychia. Sorry, this is called leukonychia. This happens in case of chronic liver disease when there is low amount of क्या कम हो जाता है उसमें chronic liver disease में. What is low in chronic liver disease? That leads to edema, albumin. That's the cause. Then one more thing is there, splinter hemorrhage. Okay, I think there are images. No, see, that's clubbing. See, there is loss of angle. You can see now there is swelling in the nail bed. See, this is loss of angle. This is called clubbing. Okay, so if the finger is like that and you touch both the fingers, can there be any space in between them? No, there can't be any space. This is called finger clubbing. This is koilonychia, right? See, spoon shape in case of, typically in case of iron deficiency anemias. Okay, so you can see, right, this general physical examination, the findings in the general physical examination basically gives you much clues that this patient is suffering from this and that, right? Then this is leukonychia. See, the nail becomes white, right? Then there is splinter hemorrhage. See, you can see some spots, right? This one, right? These are called splinter hemorrhage. It happens in case of infective endocarditis. Then there are other causes also, like there are pitting in the nail beds. Pitting means there will be dips. If there is image, I can show you. See, this is not regular. There are pits. Pits means burrows. You can see in roads, right? There are pits, potholes. So there are pitting in the nail surface. This is called pitting, and this is seen in case of psoriasis. It is a dermatological condition. You will get to know it very later. But for now, you can know that pitting can be seen in case of psoriasis. Then there comes onycholysis, right? Separation of nail from nail bed. You can see this in our grandparents, as I have also seen. Many of you also have seen. The nail gets separated from the nail bed. Okay, this happens mostly in case of psoriasis and in thyrotoxicosis also. In thyrotoxicosis means what? Thyrotoxicosis means क्या होता है? What happens in thyrotoxicosis? Thyroid hormone is low, right? Low, right? Thyrotoxicosis, it's high. It's thyrotoxicosis. Whenever the toxic word comes in our medical field, it means something is high, something is extra, something is much more than whatever is needed for our physiological functions of the body. Okay, so it is thyrotoxicosis. In case of thyrotoxicosis and psoriasis, you can see there will be separation of the nail from the nail bed. This is called onycholysis, right? This is Dupuytren contracture. I have told you, right, in the flexor compartment, you will see Dupuytren contractures. This contracture basically lead to flexion deformity of the palm. Flexion deformity means the palm, the fingers became fixed in a flexed position, right? You can't extend it unless you do it passively. You can't extend it actively, right? This is called contracture. You can see in case of Dupuytren contracture, which is associated with diabetes. Basically, not in every case of diabetes, but like in cases in which the blood sugar couldn't be controlled for a long period of time, you can see these cases. Then there comes what we will see in face, eyes and tongue. See, in case of mouth, there look at the tongue, moist or dry. I have told you, right? In case of dehydration, it will be completely dry. Also, you can see is tip of the tongue. I have told you cyanosis, right? What is cyanosis? Bluish discoloration of the mucosa. In cyanosis, what happens is there is more than 5 gram percent of deoxyhemoglobin, right? So cyanosis can happen when there is low amount of blood flow to some tissues. Also it can happen in any systemic causes, like when there can't be exchange of oxygen and CO2 properly. This can also lead to cyanosis, right? So based on that, cyanosis has been divided into two categories. One is central cyanosis, one is peripheral cyanosis. Let's come to peripheral cyanosis first. See, in peripheral cyanosis, there is blue fingers denotes inadequate peripheral circulation. I have told you, right? Whenever there is inadequate circulation, you will see bluish discoloration of the tip of the fingernails, tip of the toes. These are basically signs of peripheral cyanosis. So what are the causes of central cyanosis then? These are these lung diseases and congenital heart diseases. Right? In congenital heart disease, including Fallot's tetralogy, it happens in pediatric population. Fallot's tetralogy, there is boot shape of the heart. Okay, once you see, you will understand it later. For now, you just learn ki in case of heart diseases, also in other heart diseases also you can see central cyanosis. Then in cases like obstructive airway disease, you have heard about COPD. Very commonly you have heard. This is chronic obstructive pulmonary disease. So, in case of
One of the example of chronic obstructive lung disease.
COPD is basically a group of disorder.
Pulmonary disease.
It's basically a group of disorder. It's not a single disease. Yes, you can see many people who basically smoke for a long period of time basically develops COPD. And COPD is not a one disease, it's a group of disease, right?
See, COPD patient, emphysematic patient, emphysema patient, through his physique, in particular, it is this area, this circumference will be more. Again, it's
Barrel shaped,
barrel.
circular.
You have seen the barrel? Yes. So if the Bengali student, they will be learning from Ridongo. So its shape is like that. So by this, and he will be, the problem in such patient is there, whether the problem in inhalation or in exhalation. What do you think? Inhalation problem or exhalation problem? Spirit, we inspire what? Air. We take in air, but we don't give out air. What we give out? Huh? Gas. Inhale air. Exhale gas. Why we don't say exhale air? The composition varies. Air, if you analyze air here, go to Agartala city, go to West Bengal, go to cities, everywhere its composition is same. Its composition will not vary. The amount of carbon dioxide, amount of nitrogen, amount of oxygen, same. So air has got a particular gas concentration. Of all these concentrations, there will be a particular concentration. But in expired air, expired gas, this is not there. Here carbon dioxide concentration is higher, oxygen concentration is low. That's why we cannot call it an air. So this is always an air, but it is air. It is air. Only thing, while going in, it will heavy, we will moisturize it. In our air tubes, we will increase or decrease the temperature to the body. Depending here, see if the cold, the atmospheric air is having less pressure, but while going in, it will get the body temperature. Only at the upper part of the respiratory tract. Here it will be moisturized. 100% it should be moisturized. Otherwise, it will take up while going into the alveoli. It will take up moisture from the tissues. The tissues may dry, may become dead.
So there's central cyanosis, peripheral cyanosis, and dehydration that can mostly be seen in tongue, right? Surface of the tongue. See, in case of mouth, what do you have to see? First, look at the teeth. I have told you nicotine is the maximum amount of substance abuse that happens in our state and also all over India, right? So whenever you see a patient, this dental hygiene or caries basically comes into play. Epilepsy.
Whatever.
Sir, he has epilepsy. Epilepsy আছে মনে হয়। বউ হেরে বউ। Sit. আরে ফোকাল সিজার আছে। বউ হেরে বউ বা শোয়া কোনোখানে। ফোকাল সিজার। সিজার আছে এপিলেপসি। হ্যাঁ পড়ছে না এর ফোকাল শোয়াও কোনোখানে শোয়াও ঢোকে আবার কইলে
All of you are attending the practical, suddenly one boy fell up and immediately he lost consciousness and he became like that. Yeah? So immediately he was taken to, now he's under treatment. I think
CNS seizure problem. He has seizure problem. Chalo, then so there comes the play of looking into teeth to see the dental hygiene. So patient who is abusing nicotine on a regular basis will have dental hygiene that is not so good, right? Once you examine the mouth, you can see. Then there comes the gums. Gums, what you will see in gums? Bleeding if the gums are swollen or not. There are vitamin deficiency like vitamin B2 deficiency, which you can see the patient will have swollen gums, bleeding, there will be cheilitis, there are many other things. Once you go to vitamin B2 deficiency in biochemistry, I guess, you will learn these things, right? Then there comes smell patient's breath. Okay, this is not done in a very regular basis, but when a patient comes with a road traffic accident, you are sitting in a clinic, one patient came to you with a road traffic accident, mostly in the evening or at night. You can suspect the patient might have consumed alcohol and then drove some vehicles and then went into an accident. See, so there comes this thing of smelling patient's breath. One more thing is ketosis. There may be many of your parents who are suffering from diabetes, right? My parents are also suffering from diabetes. In case of diabetes, when a patient's diabetes is not in control, right, the blood sugar has spiked to 400, 500 like that at a constant basis, and you can't control it by any sort of medication, the patient may go into diabetic ketoacidosis. What happens is there is ketone body formation. In diabetes, what is there? Insulin is not present. Either insulin is very low, or it's not present, or it's not being taken up by our cells. So glycolysis will not be there. You have been taught about glycolysis, right, in biochemistry? So there will not be glycolysis because insulin is not there, glucose is not absorbed in your blood, in your tissues, so there will not be any glycolysis. What will be there? There will be ketone body formation. So it is called ketosis. And okay, and
what are the ketone bodies?
sir, they don't seem to be they look like they have not been taught about ketones body. They are so blank, all of them.
I understand. They are here for 3 hours.
Yes,
We started
at 2 maybe.
2 o'clock. and now it is going to be 5. So brain is
Not permitting. So we can.
so are there
Sir, I guess
how many slides?
we can finish by 10 minutes, no problem.
So we finish it by 10 minutes. Can you please let your here for 10 minutes?
For 10 minutes, okay? Bear with us for 10 minutes, right? Very long class.
Very attendance to much better will be.
So, there is ketosis, right? How ketone body is excreted? Ketone body is excreted, you know? Huh? Excreted, how ketone body? Anything produced in your body must be excreted after it metabolism is complete, right? Breath. One thing is breath. So when ketone body is excreted through breath, it actually smells like sweet. Basically, it is a fruity odor. The acetone, what is formed?
Because of acetone.
Because of acetone, it's fruity odor. So there comes this play of smelling the patient's breath, right? Then comes the eyes. Look at the sclera, look at the lower lid conjunctiva, look at the eyelid. There are three things like what is sclera? White portion, right? What is this called? Sclera. So in sclera you basically see jaundice. That is yellowish discoloration of the sclera, right? This is called jaundice. In clinical terms we will call icterus. Icterus, this is called yellowish discoloration of the skin. Then there comes lower lid conjunctiva. We have two conjunctivas, right? This is the lower lid, this is the upper lid. So for practical purpose we see the lower lid conjunctiva, right? And whenever you see, you have to see both the lower lid conjunctiva. See, if this is pale compared to mucosa of your mouth or compared to a normal person, you can understand this patient is suffering from anemia, right? So this is lower lid conjunctiva. Then there is eyelid. In eyelid there is, you can see yellowish deposition of cholesterol basically. There will be, you can see in many older patients or older people, on a general basis you will see there is deposition of cholesterol. This cholesterol is basically deposited around your eyes, around in the eyelid, right? It will be deposited around the eyelid. Okay, so this is called xanthelasma. Cholesterol deposition around the eyelid is called xanthelasma. Anything on us?
Actually, the position like small mass like this.
Yes, small mass like that. These are basically yellowish in color, and they are deposited in a ring-like fashion around your eyelid. This is basically xanthelasma. Cholesterol deposition, yes. This is a normal condition, nothing happens with that, but there is deposition of cholesterol, you can see. Then one more thing is there, excuse me, bear for 10 minutes. Then one more thing is there is puffy eyelids. In case of edema, there is accumulation of fluid. So accumulation of fluid can happen in your legs, in your hands, right? Also in your eyelids, also in the eyes. See, these are called puffy eyelids. You will see these will be swollen. In a normal person you will not see this. Once a patient is suffering from any cardiovascular cause or a gastrointestinal cause specifically related to liver or any renal cause, you can see there will be swollen eyelids. These will make you understand that yes, this patient is suffering from edema or fluid accumulation basically, right? One more thing is there, mixed edema. I have told you thyrotoxicosis, right? Or hyperthyroidism, where there is increased amount of T3, T4 levels in our body. This hyperthyroid patient can show you thyrotoxicosis. One more thing is there is thyroid eye disease in case of mixed edema. There are cases of hypothyroidism also. In hypothyroidism, what happens is there is accumulation of fluid in the gags, what we called are gags. Okay, you will learn it in biochemistry, what are called gags. In gags, what happens is there is accumulation of fluid. So even in the eyes, you will see accumulation of fluid. Even in your limbs, you will see accumulation of fluid. So in case of severe hypothyroidism, where the thyroid hormone is very low, metabolism is very negligible in your body, you will see patient is suffering from mixed edema. Patient may even undergo coma in these cases, right? These are very severe cases, very serious in clinical views, and you will see patients of thyroid eye disease in case of mixed edema cases in severe hypothyroidism. Okay, then there comes the eyes also. You can see a red eye. Red eye in case of iritis, conjunctivitis, episcleritis. This basically comes under ophthalmology, right? You will see in many times you will see red eyes. Red eyes can be caused to different reasons, right? Conjunctivitis, episcleritis. You will get to know it later when you study right? Ophthalmology. Then there comes white line around cornea, arcus senilis, which is hyperlipidemia in younger patient but has little significance in elderly. One thing I have told you around the eyelid, xanthelasma. One thing is arcus senilis, which is around the cornea, that is inside your eyes. Around the cornea, inside your eyes, there will be hyperlipidemia, which will lead to arcus senilis, right? Once you see those cases, this will be basically very clear to you. Or you go through any pictures or diagrams in Google, then it will be very helpful for you after this class is over. Else, you will tend to forget a lot of things that has been taught today, right? See, there is white band keratopathy also, so I will leave it for now. See, this is called central cyanosis of tongue. See, this image is not so clear, but when you see in the tongue, you see one thing is moist or dry, the next thing is if it's bluish discoloration or not, right? So this you can see central cyanosis in tongue. These are peripheral cyanosis. See, in the toes, in the tip of the finger, you can see bluish discoloration. These are called peripheral cyanosis, right? Then there is jaundice. Where do you see jaundice? Sclera, right? What do you see jaundice? Sclera. What is this called? Icterus. Then this is puffy eyes.
While you be writing,
See?
taking note, interest present or not.
See, these are puffy eyes. Around the eyes, there it will be swollen. It is called puffy eyes. Puffy eyes. See, I have told you xanthelasma, right? See, there are yellowish deposition of cholesterol. This is called xanthelasma. See, in severe cases, how does it look? See, it's throughout and around your eyelid. It is not inside. It is not basically inside your eye. Once it is inside your eye, it is called hyperlipidemia inside your eyes, around the cornea. I have told you just now. Arcus senilis, right? Arcus senilis. See, white line around your cornea. This is cornea, right? This one is sclera. There is thin membrane transparent. This is conjunctiva. So this is around the cornea. This is arcus senilis. These are, what is this called in both the eyes? One is pupil, one is iris. Pupil is through which light enters, and then through lens it goes to your eye, retina. And then there is iris. This is the muscle fiber. One is the circular layer, one is the radial layer. Okay. This is arcus senilis. This is one more thing. Basically, it is related to metabolism. In copper deposition in case of Wilson disease, deficiency of ceruloplasmin, which carries copper. So it's in biochemistry basically, this thing. In metabolism chapter it's there. Then this is myopathic phase. See how come general appearance comes into play. This is a myopathic phase. Okay. You will get to know it later. What is myopathy? Then only you will get to know what is myopathic phase. Okay. And see, this is edema. I have told you now, once a patient comes, you can see swollen limbs. There can be cases that the patient has just started to have edema. You can't see it with bare eyes. What you have to do is press on the bony surface. For example, in our legs, this is the tibia. There is flat surface of the tibia, or then there is tibial condyle. So basically what happens is you press on the tibial condyle or any bony surface of our body, you will see there will be pitting. See, there are pittings. What is pitting? Once you press, it doesn't come to its normal shape. It takes some time. It takes few seconds to come back to normal. Okay, this is called pitting. You will see this pitting in case of pitting edemas, right? I have told you another thing is myxedema. Hypothyroidism, myxedema. Myxedema also leads to edema. In myxedema only this word edema is there. This myxedema, in case of myxedema, is not pitting. Once you press, there will not be any pitting. So there's a difference between pitting edema versus non-pitting edema. You have to learn it, right? Pitting edema versus non-pitting edema. Pitting edema can be seen in different cases like renal failure, like chronic liver diseases. Non-pitting edema can be seen in case of myxedema, that is severe hypothyroidism. It can also be seen in case of lymphedema. Your lymph node, your lymphatic or your thoracic duct blockage. Lymphedema, right? There is lymph node. There is lymphatic fluid that is accumulated. This is called lymphedema. So in lymphedema and myxedema, you will see non-pitting edema. Okay, there will not be any case of pitting. Okay. These are erythema nodosum. Basically, in case of sarcoidosis, many inflammatory conditions of our body, it shows there are red color of spots throughout our limbs basically. And these are basically very much painful in nature. These are called erythema nodosum, right? We will get to know it later in your dermatology classes in final year, right? And this is pyoderma ganglionosum. See how bad it is. Seen in case of inflammatory bowel disease, right? Many of you must be knowing what is Crohn's disease. Yes, Crohn's disease, inflammatory bowel disease. In these cases, this thing is seen. This is called pyoderma ganglionosum. Then, now comes the ending, right? So in the end, after taking history and examination, ask the patient if the patient has any questions. Since he has come to you, definitely he must have some concerns regarding him. He might ask you, sir, when till I can expect that I will be over with my disease or I will be healthy? Or if a patient has come with a fracture, he may ask you, sir, how many days will it take to heal, and by how many days I can walk back again, right? Or I can perform my normal daily activities. So the patient may have concern, right? One more thing is covering the patient and thanking him or her at the end of examination. It was told to you in the initial part that there should be presence of screen. This screen is important for privacy of the patient. When you examine the patient, there should be a screen so that the privacy is maintained. In case of a male doctor and a female patient, there should be a female attendant present there, and it is very much good if a female doctor is present at that time. Okay, then that female doctor can examine this female patient without the presence of any attendant. But you must ensure there is always presence of curtains whenever you examine the patient. It can be a very normal examination, for example, examination of blood pressure, examination of pulse, examination of abdomen. Okay, even in case of a male patient also, you have to ensure that curtains are present. The privacy of the patient is very first thing you have to maintain. Okay, after history you should have ideas which system you wish to concentrate for examination. I have told you, right, after history taking, it will give you somewhat differential diagnosis, right? These differential diagnoses relate to many systems. One differential diagnosis relating to one system, another to another system. So once you are done with the history, you have to concentrate for examination, and you have to concentrate which system basically you will examine. There is a preference of differential diagnosis, right? I will give, for example, in case of edema and other history and everything, I am giving preference to cause of chronic liver disease. So my preference of systemic examination will be examination of abdomen first. I have to elaborately do that, then I have to go to other systems also. Okay, in your next class we will be discussing you with other systemic examinations what are there, and we will try to demonstrate it even in front of you also, right? Okay, so that's the ending.